Welcome to Module 7. In this series, we'll analyze real hospital prescriptions and see if they match the diagnosis. This case involves a COPD patient. Let's see what's right, what's wrong, and what could be dangerous. Pause this video and try to find out the errors. Okay, let's review this prescription from a hospital pharmacist's angle. Salbutamol 2.5 milligrams 4 times a day is acceptable, standard for acute airway relief. Pantoprazole 40 milligrams once daily is a routine GI protection dose. But there are red flags. Prednisolone 5 milligrams once daily, too low for any acute anti-inflammatory need. Most protocols recommend at least 30 to 40 milligrams daily for effective systemic action. Azithromycin 250 milligrams, 3 times a day. This is not standard. Azithromycin is designed for once-daily dosing due to its long half-life. Even at low doses, the frequency should remain OD. TDS increases risk of side effects like QT prolongation and GI upset. Theophylline SR 400 milligrams twice a day, borderline high dose, especially in elderly. Requires plasma level monitoring due to narrow therapeutic index. Watch for toxicity symptoms. So, in this prescription, 2 drugs are fine, 3 need attention. Here's your next prescription to analyze. Look closely. There are just 4 drugs. Simple, right? Ciprofloxacin 500 milligrams. 3 times a day, ranitidine 150 milligrams, once daily, diclofenac 50 milligrams 3 times a day, glimepiride 4 milligrams, once daily. Find out the appropriateness. Let's go one by one. Ranitidine 150 milligrams once daily. That's standard, no issue there. Glimepiride 4 milligrams OD. What do you think? Is 4 milligrams okay as a starting dose? Here's the catch. Starting with 4 milligrams can cause hypoglycemia, especially in elderly or renal-impaired patients. Safer starting dose, 1 to 2 milligrams, then titrate as needed. Ciprofloxacin 500 milligrams 3 times a day? That's a mistake. Ciprofloxacin should be given twice daily and not TDS. It has a long half-life. TDS just adds toxicity risk without extra benefit. Now here's the tricky part. Diclofenac plus ciprofloxacin. Do you know what happens when these two are combined? They are increased risk of seizures. NSAIDs like diclofenac can potentiate CNS toxicity of ciprofloxacin, especially in elderly patients. Would you dispense this prescription without clarification? Type yes or no in the comments, and explain why. Next case, levothyroxine 50 micrograms once daily and calcium carbonate 500 milligrams once daily. What's the problem here? Is it the dose, the frequency, or something about when the drugs are taken? Let's find out. Levothyroxine 50 micrograms once daily. Correct strength for a starting dose. But it must be taken. Empty stomach, 30 to 60 minutes before breakfast. Calcium carbonate 500 milligrams once daily. The issue? Calcium binds to levothyroxine in the gut. This blocks its absorption. Can lead to ineffective thyroid therapy over time. So what's wrong? Both drugs are fine individually, but if taken together in the morning, levothyroxine won't work properly. Space calcium at least 4 hours after levothyroxine. Have you ever seen this in a real prescription? Let us know how you would counsel the patient below and tag a student who needs to learn this. Let's see if you can spot the red flag in this prescription. Aspirin 150 milligrams once daily, Clopidogrel 75 milligrams once daily, Esomeprazole 20 milligrams once daily. These drugs are commonly given after heart-related events. But is this a safe combination? Look carefully. What's the issue? Aspirin 150 milligrams once daily. That's a valid antiplatelet dose, though many guidelines use 75 to 100 milligrams. Used to prevent blood clots. Clopidogrel 75 milligrams once daily. Dual antiplatelet therapy with aspirin plus clopidogrel is often used post-myocardial infarction or stenting. Now the problem? Esomeprazole 20 milligrams, OD. What's wrong with protecting the stomach with a proton pump inhibitor? Esomeprazole is a CYP2C19 inhibitor. It reduces the activation of clopidogrel, which is a prodrug. Result? Downward arrow. Clopidogrel effect? Upward arrow risk of clot formation. That's dangerous in post-MI or stent patients. So safer choice is using pantoprazole or H2 blocker instead of esomeprazole. Let's spot the error. Cetirizine 10 milligrams once daily, chlorpheniramine 4 milligrams 3 times a daily, montelukast 10 milligrams once daily. All three drugs are used in allergic conditions. But, do you notice anything duplicated or unnecessary here? Montelukast 10 milligrams once daily, leukotriene receptor antagonist used in asthma or allergic rhinitis. No problem here. Cetirizine and chlorpheniramine, both are antihistamines. Cetirizine is non-sedating, second generation, and chlorpheniramine is sedating, first generation. Combining them gives no added antihistamine benefit, increased risk of drowsiness, dry mouth, confusion, especially in elderly. What would you remove from this prescription? Type your thoughts in the comments below. Your answer might help someone. Okay, here's next case. Short and straightforward. But there's a hidden danger, especially because this patient is pregnant. Let's see if you can catch it. One of these drugs is contraindicated in pregnancy. Do you know which one? It's Losartan. Losartan is an angiotensin receptor blocker, and it is strictly contraindicated during pregnancy, especially in second and third trimesters. Can cause renal damage in the fetus, low amniotic fluid, oligohydramnios, even fetal death. That wraps up part 1 of our prescription error spotting series. Share this with your fellow pharmacy students and professionals. Thank you for watching. Don't forget to subscribe to Drugs Decode for part 2, where more tricky cases are waiting for you.